Okay, so
What does it mean?
Okay, anti-thyroid peroxidase. So, or thyroxine, like thyroid peroxidase, I don't remember exactly. So the thing is that this is the TPO is the enzyme that actually is the one of the main guys in creating the hormone itself. The thing is that antibody destructs the thyroid. And what's the histology of the thyroid? Histology of the thyroid is that there are kind of the cysts. It's not called the cysts, but still. And there's like epithelium around, which produces the thyroid hormones, which accumulates in here. So it's like a small fluids of the thyroid hormone. So the thing is that if you destroy this, so it's actually, you got a lot of storage in the thyroid itself of the hormone. A lot of storage. So maybe you lose the supply with the iodine, you won't be able to produce more, but it's okay, it will last 6 months or even more. Okay? So there's a lot of storage in there. So now imagine that the antibodies start destructing it and damaging it. So these guys are going to rupture and get all the hormones right away into the blood. So remember, we said that every time you kill a cell, something that is in the cell will go high in the blood.
Yeah.
And I gave you the examples for the liver, it will be ALT, AST. For the red blood cells, it will be hemoglobin, which will be correlated with bilirubin, and so on. For the heart muscle, there's a creatine kinase, special MB fraction. For the normal muscle, there's also creatine kinase, different type, and creatine, and so on and so on. So in here, if you kill those cells, the thyroid hormones gonna go up. So, at first, Hashimoto's disease, the book says that it sometimes starts like that. Usually, clinically, Hashimoto's disease starts by hyperthyroidism. Hyper. That's the thing. Hashimoto starts by hyperthyroidism because you open the whole thyroid at first.
Yeah.
But after some time, when the whole thyroid is dead and there is no production anymore, it comes back to normal and then to low. So the thing is that if this is the curve of the time, and there's time here, and there's the T3, T4 amount,
Start from up.
it starts, if it's the normal level, you start the Hashimoto, it goes up, and you can never go from up to down without going to the middle, right? So it goes to normal and then low. And if I guess the TSH by the blue marker, because it goes up, TSH goes low, then TSH also goes normal, and because it gets T3, T4 goes low, TSH goes up. So that's how it looks like. Time table. So one of the main problems in the Hashimoto disease is if you test the patient at that time, you're going to think it's okay.
Because normal.
Because both of them are normal.
Which day will be?
Which day? You never know. Depends on the patient. So I just want you to remember that. So if you see a patient who tells you usually she, oh, by the way, thyroid problems, 10 or 20 to 1 ratio, female to male. Who knows? Why? But still. And so if she tells you that she has had some kind of symptoms like that, now you test her, everything is okay, you say, might be the, there are 3 parts, right? This is called the hyperthyroid state, this is called the normal thyroid state, or EU thyroid. The word sometimes is called EU thyroid. And it's not the European Union, it's actually EU means normal. Sometimes it gets to the euthyroid state. So this is the euthyroid, and this is the hyperthyroid next. So you think it might be the euthyroid state of the Hashimoto, so I'm gonna tell her to come back in 2 weeks and retest her. And probably in 2 weeks you're gonna be there already. Okay?
Once in 2 weeks, that's probably sure.
Or maybe a month. But start with 2 weeks, if she's still okay, next 2 weeks. And after 2 months, if she's still okay, it means that it's not actually the Hashimoto, it's something else. And I'm going to tell you what something else can be. So that's how Hashimoto actually starts. Starts with the hyperthyroid, gets to the euthyroid, then gets to the hyperthyroid, and that's it. You can do nothing about it.
There's no medication here.
There is a medication, but you cannot save the gland. You should just give them thyroxine, which is a very easy pill. Every morning, bam, you just drink it once. But every day of their lives should be like that. They should take thyroxine all the time. And every time they miss it for a week, they get directed to the hypothyroid state. Every time the doctor messes the dosage up and gives them a bit higher, they get to the hyperthyroid. So that my friend of mine, what she had was that she got extremely hypothyroid. Then finally she got to the doctor. Doctor gave her more than she needed. So she got to normal thyroid, euthyroid, got to the hyperthyroid, became aggressive. Then she realized that she was a medical student, she realized that, so she stopped the treatment, got back to the hypothyroid. So actually, for a doctor, it's extremely important to find a very good level and always control. Don't give them drugs that say that never come back. Come back every 1 month, 2 months to give you a control. How do you control it? It's easy. You test the TSH.
And doctor, how much normal level? 43, 45?
Depends on the patient, depends on the weight, depends on a lot of things.
BMI.
Yeah, a lot of things. So, the experience gives you a lot of things about that. So, but when you are starting actually to be like as an endocrinologist, an easy control is you give them like 100 milligrams a day, and tell her or him to come back after 2 weeks. And you test the TSH, and TSH gives you a very good response. So if the level of the thyroid hormones goes normal, TSH will be normal. And by the TSH you know that pituitary knows that it's normal. So if pituitary is okay with that, I'm okay with the dosage. If the TSH is high, it means that my dosage is still not enough, so I gain a bit. If the TSH is low, it means that I'm giving her more than I need to. So I just calculate the dosages until I get the normal TSH.
Start with low, then we increase.
Yeah, you start with 100 probably, and then you go up. Like usually 100, 150, 170 is the dosage for the guys. Okay, time's up. Yeah, so continue with that. One more thing. Hashimoto thyroiditis is not painful. All the thyroid inflammations are non-painful except one. So whenever you see pain, you pick that guy. It's called the Kervans. The Kervans, which is like a cool name, and it's actually called the subacute thyroiditis, which is caused by a virus. It's a viral infection. It's usually you had the upper respiratory infection, and after you finish the upper respiratory infection, you started to have the inflammation of the thyroid with the hyperthyroidism because there's destruction. But it doesn't go that way. Decker-Mas, the subacute guy, is self-limited. It stops after 1 month. So you start like that, you come here, and you stop. And then you're normal afterwards. So just for a month, you have the high TSH, and it's painful. Remember, if it's viral, if it's subacute, if it's Decker-Mas, it will always be painful. Okay? Okay, you're free. Bye.
Bye.